Good evening, everybody. I think we all know each other at this stage of the game. I certainly hope so, right? Is there anybody on that Dr. Lin we know, Dr. Agarwal we know, Dr. Pasquarelli, he's been here before, obviously Andy. So it looks like we all know each other. So you know the team. We've introduced ourselves multiple times, so we're going to keep moving. Next slide. Again, tonight, Angie, myself, and George are all going to talk about a few things. We're going to sort of double back and just go back over the broad goals of longitudinal clinical placement. It always is a good idea, especially when you're reaching the end of a program and you're going to do the evaluation process. It's always a good idea to sort of look back at what the fundamental goals were. We're going to talk about the entrustable professional activities, both in theory and in practice, because the EPAs are the fundamental tool or backbone of the evaluation tool that we're utilizing to evaluate students. And actually, Ann Jean's going to spend a little time actually showing you the format for the actual final assessment that's online that you'll be getting. And of course, we're going to talk a little bit about how that needs to also be supplemented with narrative assessment. And again, George is going to spend a little bit of time going over a growth-oriented forward feedback model, because again, the eval process and doing these forms is all about helping students to grow. It's not about giving them a grade per se, as it is giving them opportunities for growth. And we'll certainly emphasize that tonight. And then lastly, but certainly not least, I'm going to touch on a little bit about some potential wisdom you can pass along to the students as they begin their transition into clerkship learning, which phase 2 begins in almost no time at all. Next slide. We can just pass this way. I just went through this. So, think about how far we've come since January. I mean, it's really been a long time that we've been working with these students. And certainly, I hope the long and winding road has been going uphill, and that we've been seeing them steadily improving their skill sets and their knowledge base and their ability to function in the clinical setting. That certainly has been the intention of this long-term longitudinal experience. But obviously, that's part of what we want to see in the evaluations, is how far they've come and how they've developed. Next slide. So this is where they are. So for those of you who know the curriculum, you know there's 16 months in phase 1, and we're now in the next to last course. So they're partway through the nutrition and metabolism and digestion course, which will end on Labor Day. So actually that arrow's a little off, because we're only 3 weeks away from the end of that course. And then they're doing neuroscience and behavior, and they're into transitional clerkship and phase 2, which is really amazing when you stop and you think about it. So we're obviously completing the phase 1 journey, but beginning I think a much different journey in phase 2. And again, I think when we really think about it, we're always talking about how active learning is a critical part of what we do. But the reality is that students in phase 1 are really guided quite a bit. Next slide. The analogy that I always think about when we build, this triple jump of good educational design is we try to have as tight as possible a set of goals. We try to have an objective assessment tool, which we're going to spend a fair amount of time talking about. And of course, we want a growth-oriented feedback loop. But in the phase 1 of school, in the next slide, I think it's really quite true that, excuse me. It's an annoying little cough. It's I think pretty true that that we really give them a road to walk on, and that the learning objectives that we give them are really a little bit tighter. So the example I'm giving here is these are the big learning objectives for the LCP domains, and so it was really fundamental stuff. Being able to communicate with patients and being able to talk and listen respectfully. Obviously, the pursuit of evidence and the pursuit of excellence in terms of having the student being prepared and contribute. Obviously, this idea of professional identity formation, where they literally are putting on the white coat for this first time and being seen as doctors, and indeed looking and watching you model what it means to be a doctor. And then, of course, the key issue of them reflecting on their own knowledge base, their own gaps, how they've reacted to being in settings where they don't know, and how have they responded to the feedback you've given them where they need to improve, and how has that bled into their own self-directed learning. These are all pretty big goals, a little hard to evaluate, to be perfectly honest, because they're a little bit too big. And of course, we've made it much more specific to evaluate them. Next slide. And how we evaluate is we basically use these units of work that are easily observable, and we know we need to do them. You know, the entrustable professional activities are this set of 18 units of work that we do in clinical medicine. And indeed, we've derived the functioning learning objectives in almost all of the programs, as well as the evaluation tool in terms of these EPAs. Next slide. And here they are. So if I sat you all down in a room around a table and say, tell me what you do every day in your clinical practice, more likely than not, this is what you're going to come up with. You know, this idea of doing a history of physical, creating a prioritized differential, ordering tests, interpreting it, oral presentations, written presentations, creating clinical questions, doing handoffs, working with colleagues, you know, deciding not sick, consents, procedures, etc. So here is the formal set of EPAs that we're actually utilizing, not just in LCP, but we're using extensively in all of the clerkships the students will be doing, as well as electives. Next slide. The entrustable professional activities we focused on and will be evaluating in LCP are really specifically these 7. Of course, EPA 1 with the history and physical. Of course, EPA 14 with communication skills that we've just discussed. EPA 17 is about growing and professional growth in a clinical environment where you're getting feedback. EPA 18 is all about the determinants of health, which is so critical to taking a basic history and learning what's going on. And then more recently, in the latter part of LCP, we've really been focusing on them creating prioritized differentials, doing their write-ups in more detail, especially with summary statements and with plans, and of course, honing their oral presentation skills. So these are the domains or EPAs that have been selected and mapped for evaluation in LCP, and the eval forms should reflect this. Next slide. Now, the School of Medicine, you always talk about eval being formative and summative, but for the most part, everything you're doing in LCP is really formative. There's no end quote unquote grade in LCP. It's all about growing them. It's all about identifying these skills and helping to push them along the competency curve. And we don't expect them to become quote unquote competent in LCP. It's probably not possible. Not enough time and exposure. It is all about moving them along the curve of growth. It's not about giving an absolute grade. So behavioral anchors, because it's almost impossible for students at this early stage to be able to do this. Next slide. So again, the check the box evaluation that we talked about and we're going to look at real quickly is absolutely essential, but it's absolutely necessary but not sufficient. In order to really round out the evaluations of students, you really need to give narrative assessment. That is, give specific examples about the performance of the student, especially about their progress, how they interact with people, how they respond to your feedback. It really is critical feedback for us to systematically change some of the curricular offerings that we do. And I think concrete examples are the best way to give narrative assessment. Next slide. And again, they should be task performance and observed behaviors that are the examples. And ideally, they should be SMART. That is pretty specific, measurable thing that you think is reasonable for a student to achieve, that's obviously relevant, and give them some sense of a time frame of it. And of course, it's so important, giving narrative assessment to help the learner sort of reinforce their strengths, but also, most importantly, to help them move along the competency curve and improve with deliberate practice and repeated evaluation. Next slide. So what does the comprehensive evaluation tool look like? Basically, in its paper version, which you actually won't see, you'll only see the electronic version, it's simply the listed entrustable professional activity domain. And underneath it is a series of 4 boxes. And in each box is a behavioral anchor that describes the behavior that indeed you may choose from. Always on the far left is the student who's got lots of opportunity for improvement. On the far right is an unusual student who's actually reached competency. It's unusual to find that. And actually, if the next slide, you'll actually see what it looks like. This is what the paper version of the CET looks like. And you can see here, for example, EPA number 1, the history and physical, the first behavioral anchor talks about the student being unorganized without coherent structure. And the third box, which is competency, is that they're well organized, logical, and mostly driven by clinical reasoning. So you can see here that these behavioral anchors will help you sort of define what it is you're looking for and help you to indeed grade the student. And in addition to that, the EPAs also sort of give you an idea of whether the case is complicated or straightforward. Probably in most of the settings you're in, it's probably pretty straightforward, mostly. Next slide. So with that said, I am going to pass the baton to Angine and have her talk about the actual form you'll be seeing.
Thank you. So based upon what Dr. Giuliano was talking about, is we created the Google version of this year's CET form. Jumping off from what he was talking about is that we're trying to emphasize with the students, with the preceptors, that this evaluation is meant to provide feedback with the goal of growth and development of skills, that we're not expecting students to attain a competency level of skill at this point in their education. This has been their first opportunity to be in the clinical setting. And what we're looking for is, where is it that they have developed and what set of skills do they need to continue to develop? This form actually is brought forward and utilized in the clerkship environment. And so we use it to assess growth and competency as they go through the remainder of their clinical experience, and with the goal that they should be achieving the target behavior and hopefully even exceeding the target behavior by the time they're ready to graduate. So our expectation right now is not necessarily that they're at the target behavior. All right, or that they would be at the target behavior across the board. So we really want to encourage you to give some thought to where the student's skill set is at this point, because it's not translating into a score or a grade for them. It is translating to a meaningful place for them to begin their goal setting for their clerkship environment. So just to show you the example, all of that is expressed in the instructions for the form for this year. And then we take the different EPA competencies, same as are laid out in that paper form, and have just translated them into an electronic version that goes over the areas of organization, of content, then going into differential diagnosis generation, in terms of the oral presentation skills, written skills, the professionalism, communication, and systems and solutions, and for you to give an idea of where they're at right now so that they can create a foundation for which they can go forward with into their phase 2 part of their curriculum. And so essentially that's what we're aiming for with this particular form and the goals for this year. Is there anybody have any thoughts or questions? The idea is also to streamline it for you guys, because we're really trying to focus on what are you seeing happen most of the time? And can you just sort of rate it in where it matches that particular behavioral anchor? I know I have different people commuting and so forth, but any thoughts, feedback, concerns? Does it seem pretty straightforward, hopefully?
I have one question,
Yes.
because I have students in LCP, 2 of them, but I'm also an educator for them, and I'm teaching them, and we are learning. We're trying to establish that they improve with each session. So when in middle of the cycle, I think I'm at 7th or 8th right now, I'm giving them a feedback. The language of missing key information or contains inaccurate information seems a little bit harsh to me at their level because they're still learning. This is the first time they're actually seeing patients, in their career. I would have framed it differently instead of using these negative terms, inaccurate or missing, maybe lay out more specific things that covered this section, but this covered whether, all the sections are covered. Something like giving them still a little positive things that they did 5 things, they missed out 3 things without actually saying this was inaccurate or it was wrong, because they will make mistakes. And I feel I just find it a little harsh at this level. Maybe next year, yes, because
Mhm.
expectation has to be much better with the clinical clerkships. That's going to start in November and December. That's my only feedback on this.
No, I think, and I think that's very good, very, very meaningful feedback, in all honesty. I think what's one of the reasons that we took the mid clerkship review that was created this year and did not put the various behavioral anchors, but looked solely at the target behavior and tried to say, is this developing? Is this an area for further development? Are they working towards the goal? Are they at this goal already? And so changing the language, and that may be the movement we make towards this into next year. We're in a transition of having utilized the CET form in its original format as part of the LCP experience, and you because it is used in the clerkship experience, but also now making meaningful adjustments to be able to look at it as a growth and formative feedback tool. So I appreciate the feedback, and I think that that is something that we can look forward to going for, in future steps related to
Yeah,
this. So thank you.
it's a great point. I mean, in the effort to standardize the process, we have utilized this form across a very broad educational spectrum. And as you've pointed out, I think that draws into the issue of, well, what are our expectations for a student like this? And is the scale really appropriate? And it probably needs more boxes to the left for students like this. And I think you're absolutely right. I think the comment's been made at the clerkship level that the language tends to be a little bit negative even for them. So there's a well pointed points and quite frankly work that needs to be done by the assessment team to indeed change and potentially customize the eval forms, still using the same format of EPAs, still using the same domains, but actually customizing the behavioral anchors. That is an immense amount of work to validate those tools. But I know that this is an issue that's been raised for now at least 2 years since we've moved to standardizing, and clearly will be addressed. And if you have a real interest, we'd love to have you maybe even be part of the subcommittee that's working on it at the school.
Yeah, we can discuss that later on. Sure. Thank you.
With my students, we did sit down and kind of discuss at the mid clerkship evaluation. I don't know if that's what it
Mid preceptorship, yes.
There we go. Thank you. And so I did, give them feedback and everything. And I know that in an email and during these sessions, we discussed that they would like give us a form to fill out at that time. I went back to the email and then I saw that you guys also attached, like, if they don't give you one, here's one too, which I never actually filled out, even though I gave them the feedback. So I'm just curious what your suggestion is. Do you think that I should go back and try to fill in like what we discussed, or at this point, like just wait until the end of, preceptorship evaluation?
Andy, I'm going to always encourage you to consider filling out the form. I appreciate the time and effort that it takes to do so, but I am going to encourage you to do that. I do think that if there's any question about the conversation or the feedback that was given in terms of the growth in the students' overall performance, then we have it documented to be able to show them, the the
Okay.
conversation and points that were made over time. My apologies, I have the dog factor now going on. But I do think it's always very meaningful if we have more points of contact, in terms of getting those places for feedback. Dr. G, your thoughts?
I couldn't agree more. More is more. And the more data points, and especially because of the issue of sort of seeing their progress, I think it's really critical. It's why we have a mid LCP eval in the first place, is sort of get an anchored point and then a point at the end of the assessment. And what we're eager to see is the trajectory of the student. I mean, I actually just had a almost end of eval with my students right now. And actually I talked a lot about where they thought they have developed and where they need more development. So I think it's that trajectory issue that's so critical, and documenting it, I think, is always important.
All right, I'll go ahead and do that. Thank you.
Thank you, because as I said, I do know the time commitment it takes to fill out these things.
I want to say something just because it's a very strange position. I do clinical skills sessions with the students, and two of those students are my LCP students. So it's kind of awkward. And I did tell them that they have a choice to, switch the group so they can have exposure to different preceptors. But they seems
That's
to be
unusual.
happy so far, so I'm fine with it, I guess. But I don't know what are your thoughts on this, to have the same person doing both the sessions?
No,
I
I
don't-
think that's a very good point, and I wonder if we've ever encountered that before.
Never happened before.
Yeah.
Never?
I come in, I sit in and either fill in and or do observations where I see my LCP students, but it's usually a one-time event. I don't have them on a regular basis, and that's, I think, the first time I've ever heard that happen. And probably we should probably tell the CS, the CS people that are the clinical skills people that are doing the course,
Yeah, I told
to
Mookie
let
today,
us
so
know if
yeah.
that overlap actually happened, because I didn't know that.
Yep. I guess
Then
it's good because I know they're doing abdomen, because I did abdomen, acute abdomen. So I had LCP students. I showed them some pediatric patients with, perf epi. So they were so happy. So I guess it works out because they're able to see the actual cases instead of standardized patients. But it's too much of me. That's
Yeah,
what was
I agree.
bothering me.
Yeah, if we could plan it, we certainly wouldn't have planned to have that happen.
Yeah, is this a new assignment for you, or are you carrying forward the group that you already had?
No, I have every year the first fresh, the group of CS. So this is my third year with CS, or fourth, but each time I have a new set of students, small group.
Okay, but you're doing from always on Tuesdays, or you carry forward with your
Tuesdays, no,
cohort?
Tuesdays,
Okay.
yeah.
All right, so this is a new assignment. So you just essentially got these students.
Correct. This year, yeah, we started, I think, last
Okay.
month, correct.
So I think that helps us. That's very good feedback, because I think that helps us in our planning for next year too. It's another column in that.
Sorry, I keep making.
No. It's a very good point. And as you said, we've never had it happen before, but I think it's another point in our planning that we need to identify if there's any faculty teaching in another setting, would we have a conflict at the same time? So
And
thanks.
then just to add on, when I'm doing a substitute for summative OSCEs, some of these students end up coming there too. So
Well, there should be no reason you can't be objective about their assessment.
No,
I mean,
I have, yeah, correct,
yeah,
yeah.
unless
But
unless you have some kind of medical relationship with them, and then you shouldn't, obviously.
yeah, okay, just saying it out there. Thank you.
Yeah, I sit in on the OSCE sometimes, and obviously I have some of my LCP students or small group students I've worked with. You have to just stay objective.
In the preceptor experience, we heard some feedback from our preceptors that you were looking for some general idea of what the students' impressions were with the LCP experience. We took aggregate data looking at visit 3. The students are surveyed at visit 3, 6, and 10 to be able to comment on their LCP experience and to what degree that they feel it's fulfilling the learning objectives as presented to them. And so we just want to bring you 2 points of reflection that were brought about in our to our dean's cabinet meeting about last month. So looking at visit 3, when we asked the students, my preceptor is engaged in my learning and supports my ability to meet expectations, you can see at the time of visit 3, almost 94% of the students are strongly agreeing with the statement. And so a very positive experience, a high level of engagement. And this is what we're hearing from both our students and from our preceptors, that your degree of engagement and investment in this program is substantial. And then the second one here is so looking at some basic skills. So in terms of performance of a partial or full history, that the preceptor provides you opportunities to be able to practice and refine these skills. Again, we were talking about approximately 88% at the point of visit 3 of students were participating in a partial to full history in an strongly agree category. So the vast majority of students are not only feeling engaged in the process, but also getting to achieve the skills that we are setting out for them.
As we've just talked about, this triple jump of every good educational design always involves these clear learning objectives, which we've gone back over yet again. Assessment in the model of the EPAs that we just reviewed in detail, and hopefully everyone has a pretty good idea about it. But we thought it was worthwhile to just spend a few minutes retouching on the growth-oriented feedback. And I think we've emphasized that these evaluations are really driven by helping students to grow. In order for that to happen, we need to give them growth-oriented feedback. So we thought it would be worthwhile just to touch base again on the feedback model that we've already covered, but we just thought it would be worthwhile to spending 2 minutes on that.
So, any type of feedback, you want to give that, at a certain time interval, and set time aside. And I know, well, in your offices, you have, your little break rooms and things, and some say, okay, right after, the visits, we talk to the students, some, lump them together after a couple visits. So well-timed, you're observing, behavior on your firsthand observed data. Is what you're doing. You're not making any pre-assumptions, that, well, someone came in as an EMT, so they should know this or not. You're looking at the observed behavior of what they're actually doing, in the patient room. And of course, quantity, you're not going to give them 25 different things at once because their head would be spinning. So you're going to concentrate on what their goals were, for that session and say, okay, let's look at those, 3 items or 4 items. So in our, school, we came up with a feedback conversation model. It's based on the R2C2 Canadian model. And we go around a clock face, in a circle. And in the middle of that, you see a double arrow, which is very important. And that shows the relationships. It's of a give and take between the preceptor, and, the learner, the student. And so it's not just you shoving out things and saying, hey, you did well with this, you didn't do good with that. You have them coming back and saying, wait a minute, I don't agree with that. Let's get on the same page. So you start out at the top with goals. And, all our students, when they come into medical school for all their courses, they're all very versed in writing goals for their courses. So as you've known by now, you can finish up your session and say, well, next week, when you're coming in, or next month, come back with, 3 different things about improving, your communication with the patient, so that it's more easier to examine them, for example. And then, we go around that clock face. Self-assessment is important, of saying, well, what does that student think, the learner think of how they've done, and you'll find, 2 spectrums. one person to say, oh, everything was terrible. I didn't do anything right. And then on the other spectrum, they'll say, oh, no, it was perfect thing. So the reality is that you as the preceptors gauging back and forth in that double arrow relationship again and say, well, wait a minute. No, you weren't that terrible. You did these 3 things good, but you could improve on this. And so you come to, a middle of the road, agreement on what are your gaps and strengths, of that particular student, in the practice that's working with you. And once you do that, then you can have an outline of a coaching plan, to improve and actually, have them have an individual learning plan and get them for a lifelong learning plan in line. And then go back again for more goals again and around again. And as we said, you have to have each of those coaching plans and goals to be specific, measurable, attainable, relevant, and time-based. You can't just tell somebody, oh, you should read more on this topic. Well, read more about what? Okay, you're going to read more about, radial, catheterization, as opposed to, brachial catheterization. And look it up. I would suggest, look in some of the references in the PubMed side of things. 1 minute preceptor model for fast feedback is a series of 5 micro skills. And you're always, of course, focusing on the patient. On the learner side, those 5 micro skills is you're getting a commitment on what's wrong. You want to have the evidence there. You want to say at first, well, what did they do right? Because it's always better to say what they did right rather than starting out what they do wrong, because they'll be more inclined to listen to you and, and listen to what you have to say. And then you're just, teaching a general principle, of what the goal of the subject is, and then correcting any errors, that would come up. The 5 W's is a remembering tool and research, basically what's going on, why do you think of that, when you think it is, oh, whoops, I forgot about this, you might have thought of this, and the warm, fuzzy light bulb going on saying, oh, that's a good thought there. Then we're going in back to Dr. Giuliano again.
Yeah, I think the feedback models, the 2 that we've just proposed, one I think is really kind of model that you can use at the end of the day for a defined period of time. Take people aside and really talk about sort of what happened today. The other model is very freeze dried, and you can utilize it really in between every single patient. The armed services created the warm, the 5W abbreviation for the model to help you remember it. And anybody can start using this. And I use this all the time in between cases, and then do a little bit more of a formal sit down. And I think most people, that's how they found it, most effective, is to sort of do mini little feedback, 1 minute preceptor modeled feedback during the day with each case, and then a larger relationship related discussion using forward feedback at the end of the day. Let's go back forward. So again, coaching and going from phase 1 to phase 2 is really actually a major issue. I think our students, moving into med school, they really, that transition, I'll be honest, is, it's school. We say they're doing active learning and it's a little bit different. And yes, there are more activities, but the reality is that we still have a pretty tight control over a lot of the things that they do. And that transition is that they make into phase 2, I think, is a much more dramatic transition. And that's about what's about to happen. So we thought it would be nice to spend a little bit of time talking with you about potential ways in which you can coach them to make that transition. Next slide. So when I think about phase 1, it is active learning, but I think the analogy is, we built the roads and they let them drive, but they can't go off road. They're going straight ahead, left, right. We really give them boundaries about what to learn, how to learn it, and give them quite a bit of structure. But when they get into phase 2, the model's completely different. And the analogy I use for phase 2 is an ocean. And now they're sailing out on an open ocean, no roads. They're completely and totally being swamped by a flood of information. People talk about drinking from a fire hose. they're drinking from an ocean. And unless we help them understand, how to prioritize what knowledge I need to bring in, how to steer through all of this information with a rudder, how to use sails, the completely different equipment, I think they're going to get lost. And I think it's really important that we help them to recognize that it really is a different environment and they need a different set of skill sets. Next slide. And when I mean a different set of skill sets, I think it's really important that they, for example, don't get carried away by the most interesting zebra on the floor and they haven't addressed appendicitis yet. So invariably what I find, especially faculty does this all the time, let's give the medical student, the most rare zebra on the floor for interest, and they haven't done the most basic. So it really is important they know what the learning objectives are, the list of the core learning objectives in their clerkship or elective, what the core list of diseases are that they expect to see, and what the core list of problems they have. And I would actually, one of the pieces of advice I'd give students all the time is when they're getting and looking at their orientation, pull out the learning objectives and indeed pull out the diseases they're expected to see and pull out the problems they're expected to address, put it in your pocket and actually check them off as you go and use it to help guide them in terms of what learning objectives they're trying to accomplish this particular day. The other thing that's really critical is that they sort of, obviously they've got to bring incredible curiosity and a respect for the people they're going to work with in terms of an interprofessional environment, but they've got to start being able to navigate in an ocean, which means they've got to be able to use Epic. They've got to find labs. They've got to know how to find where procedures are being done. They have to know how to use notes, how to write them, how to draw from them, how to create oral presentations in particular settings that they're in. These are all skill sets that will be either unique or in a very different kind of environment. Could you imagine them doing a 20-minute presentation in a surgical or an emergency room environment? They would last about 10 seconds, right? And of course, how do you address the knowledge gaps? There's going to be 100 knowledge gaps every day. How do you prioritize? What do I study tonight? I have a couple of pearls that I've collected over the years from various clinical attendings that have been working with students and for myself that I think are really important. And I would just offer these up as potential elements or talking points when talking with the students as you coach them as they prepare to enter the clinical world. I think students often feel like they're sort of thrown into this ocean and they're all by themselves. And I think you have to emphasize to them that there is a ton of people around them who can teach them. The nursing staff is their best friends. Utilize them. They can teach them immensely. Nurse practitioners, residents, obviously the attending physician who's responsible for their education, but all of these people can assist in their educational process. Of course, don't be shy about asking questions. Often I hear students say, if I keep my mouth shut, well, maybe they won't realize how little I know. Well, they need to be encouraged to ask questions, encouraged to say, I don't know. And then, of course, query people to get the answer. Obviously, having a relationship with the patient is so critical. Having people observe them develop that therapeutic relationship is absolutely critical. We do not watch our students interact with our students with our patients very much. It is really critical that they make a point of saying to someone, please come watch me and give me feedback about how I do with the interaction with the patients. Make sure that they indeed feel empowered and emboldened to share a physical exam finding. Somebody one day, the other day in the neonatal unit was doing an exam on the baby and they did a very thorough exam. And they noted aplasia cutis congenita on the back of the occiput of this infant. And no one else had noticed it. I hadn't seen the baby yet, but residents had missed it. The nurses had missed it because the kid had a hat on and no one had really done a really thorough exam. And that aplasia cutis congenita was a critical finding in the overall differential for the infant. So, have them share findings, whether they're historical findings or physical exam findings. Obviously, encourage them in the idea of not being alone to create peer learning communities. Most of them do this on their own, but you really want to make sure that they have each other in terms of each other's backs. And of course, work with the medical team to try to form a committee, form a team for purposes of learning. And of course, I think last but certainly not least is let them know that the clinical world is not a multiple choice test with a right answer. There's always uncertainty and ambiguity in the clinical world. There is often not an answer when you begin to embark on therapeutic interventions. And I always find students sort of really uncomfortable with uncertainty and ambiguity. And I usually spend a little bit of time introducing them to the idea that you're never going to be completely certain. That would be very unusual. And they've come from a world of the answer is B. And they've really got to understand that the answer is not just B. It might be A sometimes, and every once in a while, in rare circumstances, it might be D. And they need to come to understand that variability and uncertainty that comes with the real clinical world. So this is just a simple set of, I think, a couple of points of wisdom that I share from both personal experience as well as working with other people, and I offer them up as talking points when you work with the students. And I'd love your comments in a second. Just two more slides, and then we'll talk a little bit. Next slide. Again, obviously in the learning environment that they're moving into, the primary thing that they are learning from is watching us. They are watching us all the time. And you can say whatever you want, but what you do and how you act and how you treat your patients and how you treat the nurses and how you talk about your colleagues and how you act as a professional is what they are going to learn from. And you can say all you want, but what you do is what they're learning from. So it really is a model of real life work and apprenticeship. And just be aware, you are on stage and you are being watched all the time. And I think most of us are aware of that, but every once in a while I hear feedback from students telling me the activities and what some faculty do. And I have to be honest, I cringe a little bit because they are watching. Next slide. And again, of course, they're learning in the real world by participating. So the more responsibility we give them, the more learning I think they're going to do, especially in this kind of rich environment that we work in. Obviously, you can't let them do things they're not prepared for, but is really critical. For example, you should always encourage them to write notes. Writing notes really gets them into the process. And indeed, those notes obviously need to be evaluated. And those notes need to actually sometimes be incorporated into our own notes. So give them as much responsibility as possible in the real live environment. Next slide. And again, this is again focusing on the fact that you really need to encourage the students to really be attentive to their orientation, because that's where they're really going to get the nuts and bolts of being able to function in this completely new environment. Making certain they really read the outline of their clerkship goals and objectives, and not just sort of put it in their pockets and never see it again. Next slide. And again, the perception of students is really sort of interesting. This is an article that was written about students' perceptions. And again, it's unbelievable to me how the students feel like they're not being properly prepared. It really is critical for them to ask critical questions in the beginning of the clerkship so they understand what the expectations are and that those are crystal clear. Just as we talk about the 1-minute learner when we interact with students, when we start working with them at the clerkship level or at the elective level, they really have to be explicit about what is the expectation, how many patients, how do I get going, what's the expectation about presentation and charting and questions, all the things that we've talked about in the 1-minute learner. Next slide. So this is the specific feedback we've gotten actually from Angie and Anthony, who wears more hats than one, and a number of other clerkship directors who actually talk about the students when they show up. And the three things that have come up multiple times, and this is again key feedback and maybe skill work that we can do over the next couple of months, is really helping the students to have hypothesis-driven histories and physicals. That is, they're not just going through a checklist, but they're actually thinking about, well, I think this patient might have appendicitis, so I'm asking about, did the pain move? Was there a fever? Is there associated vomiting? Is there associated other findings consistent with, show me where the pain is and do they point to McDermid's point, etc. Are the students doing a more comprehensive assessment? That is, indeed, their assessment statement is more complete with a diagnostic plan attached. And of course, are their notes detailed, especially getting into the justifications for differential diagnosis? These are three areas that the faculty and the clerkship faculty have really specifically said they'd love to see more work done. And obviously, we still have the rest of August and September to work with our students, and these might be areas that we focus on. Anjean, would you like to comment before we move on to a few announcements?
Honestly, I think that you've hit it on the nail on the head. It's really that we, from the clerkship standpoint, we want to see the students continuing to expand those differentials, moving it beyond the top three, having them really delve into, the potential things. One of the things I always say to them is that real life patients don't look like standardized patients. So we have a lot more nuance, a lot more caveats to what's contributing to their presentation. And so that they need to keep having that reinforced. And the concepts of beginning to build an assessment and plan, that we move them away solely from this focus on pharmacological interventions, but what are both pharmacological and non-pharmacological interventions? What types of patient education? What types of anticipation and prevention can we use? How do we incorporate follow-up as a gauge for acuity and for need to reevaluation as part of the treatment plan? So having them start to think in those ways when they're working with you as well can help prepare them very well for clerkship.
Those are all excellent points made by a family medicine practitioner. I can hear your family medicine training clearly coming through. Well, let's just go ahead. A couple of more slides, George. Go ahead, next. I just want to real quick announce, September 10th and 17th are the two dates for the next workshop. There'll be repeats, so pick one or the other. You'll notice one's at 5:30, the other is at noon, so a little different in terms of it's not on the same day. Please ask everyone that you know that does LCP. We certainly would love to get your reflections on how things have gone this year, what you thought went well, what you thought needs work, and how we can make more teaching be embedded in your workflow and make it more efficient. So please join us on those dates. Next slide is just your attendance. So please thank you. Of course, a thank you. Make sure that you use the QR code or the link to get your attendance. And we do have a few more minutes. So I'd love to hear your comments about the last few things that we've talked about in terms of both pearls from your experience, whether those resonate with you or not. And of course, the elements that the clerkship directors have told us need a little bit more work. And I'd love to hear your feedback about both of those things.
Hi, Michael. Sam here.
Hey, Sam.
Can you hear me? Hi. Good to see everyone. So I think one of your pearls about, I don't know, creating a safe environment for them and assuring them that you don't know is something that very acceptable. And also, I don't know a lot of things. And once you give them this safe environment, you actually find them that they know much more than what they expect that they know. And what they have taken through the courses now, especially now those who are in Unit 3, they do know a lot more than what they think that they know. And all what you need is just to give them that safe environment that they will be able to speak and hear themselves and form that differential diagnosis. And that hypothesis-driven question that they can start now to think about what is the most common, what is given now so far, and how can I think of it? So I find that this is, once I give them, and you know what? If you don't know, if you say something wrong, this is the best thing happened to you today, because now you're going to get to know it. So
right on
that's
target.
why I'm here. Yes.
I couldn't agree with you more. It's probably the most important thing you can do to create a safe learning environment is just be honest about your own ignorance. You know,
That's right.
obviously model that that's okay not to know, and then of course model to go get the answer. But
Yeah.
I couldn't agree with you more. I think it's one of the most powerful things we can do. Nothing worse, you know, than the know-it-all, either resident or attending, who even mocks somebody who doesn't know something, or you talk about creating a chilling environment in the educational world very, very quickly. So couldn't agree with you more. And as George pointed out, the feedback model, especially when you're giving corrective feedback for improvement, really requires you to have a relationship where the student understands that this is all about them growing and getting better. And when they understand that's your primary job, and they understand you're learning just like they are, you usually are 9/10 of the way up a learning environment that's going to be positive. Other
Absolutely.
comments at all about what we've suggested? Dr. Pasquarelli, quiet
Hi,
tonight.
folks. My students have done a very good job with the mechanics of a history and physical. So that's really the best that it's been in the last 9 months. But we are working on the impression and plan and the problem list, and that's what we're going to tackle over the next 6 weeks. So
Good.
I think it's been a good transition, but they've got the mechanics to interview a patient well. For clerkships, I tell them very honestly that, a doctor, nurse practitioner can come in and write all the orders, but who gives the care? That nurse. You have to have a relationship with the nurse of the patient. They're going to help you give the care to the patient. I also said, work with a nurse, have them you make a bed, transfer the patient from a bed to a wheelchair. Get the feeling of how you actually take care of the patient. Even if you want to go down with transport, how to get a critical patient on a vent to like the CAT scanner. So I really said the relationship with the nurses, you just said, is extremely important because they're there 12 hours a day. They interact with family, and that's a way that I learned through my residency, even though I had great role models. But the nurses, I thought, were the people I learned from what the day-to-day care was. So it's a really good thing what you said about the pearls. Relationship with the
Yeah,
nurse.
I think that's
Going to
critical.
take
Yeah.
interest. And
The
the
nurse is your best friend
So-
or your worst enemy.
Agreed.
And if you give them respect and you engage them and involve them, you ask before you do anything, ask them for help for understanding, and show them the respect that they deserve, man, they can be your best friends. You ignore them,
Totally
or you're condescending, they're going to eat you for breakfast.
agree.
And I'm married to a nurse, so I understand that well.
I'm married to a nurse too at Hackensack, so we have that in common. Yes.
Superb. Very good. Well, I enjoyed the comments. They were excellent, and especially the comment about the eval form in terms of it being probably for an older group. And I think they're exactly right. And probably we do need to move to having customized stuff for different students at different levels. And that was very insightful and something certainly that we're going to work on. But I want to thank everyone again. It's 6:30, and I do not want to get between you and dinner. Thank you for those of you for all that you do in LCP and the work you do with our students. This program wouldn't exist without you. We really appreciate it, and have a great evening. Thanks, everybody.